Good evening, students. Please confirm if the audio, video, everything is fine. Please let me know if you have joined in. Good evening, Nikesh. So let's start with our INICET May 2025 recall session. So if I have to analyze the questions asked in oral and maxillofacial surgery, I would say there were around 3 to 4 difficult questions which were actually postgraduate level topic questions. Apart from that, the questions which were asked could have been easily answered based on our notes, on our YouTube discussions, on our discussions on the WhatsApp group. So more or less, I would say, except for 3-4 questions, rest all your questions were doable if you have thoroughly gone through the notes and if you've thoroughly gone through our YouTube sessions and other WhatsApp discussions. Good evening, Pratibha. So let us start. Okay. So I'll be keeping the discussions very short, especially for direct questions. I'll be keeping the discussions very short. We won't be going into the details. But questions which are new and which require a little, going into the detail in theory or which require to be thrown light on, those questions I'll be taking up in detail. Otherwise, we're going to keep our discussions short. So let's start with the first question. It says, which surgical technique is indicated for removal of a part of jawbone underlying a soft tissue malignancy? Okay. Now, this is a twisted question. Although the concept has been taught to you in the class, this is a little twisted question. Now, I would like to just go back very quickly to our two very important topics that we have, two very important aspects that we have discussed in our classes. One is marginal resection and one is segmental resection. Okay, and this is something that if today's session is being attended by students who are going to who are fresh interns who are preparing for next year, so that's why I'm explaining this here, that this is going to be helpful for them as well. Okay. Now let's say this green part is a soft tissue malignancy. There is a soft tissue malignancy here. Okay. Fine. Now if we have to resect, we'll go 1.5 centimeters below anteriorly, posteriorly, and above there is no clearance because there is air. Alright. So we will resect this part. Okay. So this becomes your marginal resection. En bloc resection, where a block of bone or a part of bone is removed. Okay. Or resection without continuity loss. Now the next thing that I'm going to explain is a potential question which can be asked in your future exams. So if this, they say there is a soft tissue malignancy, please pay attention to my pen. If there is a soft tissue malignancy invading the underlying bone or eroding the underlying bone, so I will just write it over here. Please add this to your notes. Soft tissue malignancy invading underlying bone or eroding underlying bone. In that case, wherever you can radiographically see the erosion, to make out the erosion or radiographically from the point where you can feel, okay, up till this point the invasion is taking place or the erosion is taking place, from that point you have to take 1.5 centimeters and in every direction. Okay, and above we have the air. So in this case, this will result in a segmental resection. Or resection with continuity loss. Alright. So please keep this in mind. I'm quickly going to repeat. If you have a soft tissue malignancy which is just sitting on the bone but has not caused any erosion of the bone, has not caused any of the bone, then margins with marginal resection. But if there is a soft tissue malignancy which has caused invasion or which has entered into the underlying bone, then the most probable thing to do is to get clear margins to a segmental resection. So I hope this is clear. Alright, now let's get back to our question. It says surgical technique indicated for removal of a part of jawbone underlying a soft tissue malignancy. So the answer here would be marginal resection. Marginal resection. So here we are removing either a part or block of bone. Underlying bone is free of disease. Okay. Now let's come to the second question and I'll read out. During extraction of maxillary premolar, the root piece is dislodged into the maxillary sinus. What is the immediate next step? Your options are: option A, leave the root as it is and prescribe antibiotics; B, irrigation and suction of the socket; C, curettage of the socket; D, removal of root via Calvel-Luke procedure or endoscopy. Okay, so again, this is a straightforward question. We have in our notes mentioned under the indications of Calvel-Luke procedure that if there is a displaced root into the maxillary antrum, we will go for a Calvel-Luke procedure and remove the root. Alright, so option D, removal of root via Calvel-Luke procedure or via endoscopy. Alright, coming to the next question, which syndrome is most commonly associated with mandibular ankylosis? Option A, Proteus syndrome; B, Klinefelter syndrome; C, Hallermann-Streiff syndrome; and D, acrofacial dysostosis. Now this is a difficult question, alright, and also not a straightforward one. I'll tell you, it is definitely not seen in Proteus, it is definitely not seen in Klinefelters. Okay, now there is confusion between option C and option D. Alright, now in acrofacial dysostosis there is a variant known as Nagar syndrome. So there are various types of acrofacial dysostosis. One of the variant of acrofacial dysostosis is Nagar syndrome. Alright. So it is said that in Nagar syndrome, TMJ ankylosis is seen, but is a very rare entity. Similarly, for Hallermann-Streiff, it is said that TMJ ankylosis is seen, but it is a very rare entity. However, there are certain conditions which are associated with Hallermann-Streiff syndrome, which increase the chances of patient developing TMJ ankylosis. Alright. So C and D both are associated with TMJ ankylosis, but it is not the primary characteristic features in both of them. In Hallermann-Streiff as well as acrofacial dysostosis, TMJ ankylosis is associated, but it is not a primary characteristic features of either of these syndromes. However, if we have to choose one between the two, we will give preference to Hallermann-Streiff over acrofacial dysostosis. Now just quickly we'll have a look at Hallermann-Streiff syndrome. Okay, so it is also known as oculomandibular dyscephaly. Oculomandibular dyscephaly. So its clinical features include bilateral congenital cataracts, bilateral microophthalmia, craniofacial disproportion or bird-like feces. Where do we see bird-like feces? In faces in TMJ ankylosis also. Mandibular hypoplasia, forward displacement of the mandibular condyles or the disc, high arched palate, small mouth, multiple dental anomalies, proportionate small stature, that means the patient is going to be smaller in stature proportionately, that is throughout the body. So now various books and authors say that specific features like micrognathia and anterior disc displacement of TMJ increase the likelihood of ankylosis. Alright, due to this particular point, TMJ ankylosis is more likely to be seen in Hallermann-Streiff as compared to acrofacial dysostosis. Okay, so in future, if you have to mark in this order: Hallermann-Streiff followed by acrofacial dysostosis. All right. Now, coming to the next question: in a simple symphysis mandibular fracture, which of the following treatment options are incorrect? So option A is 2.1 mm mini plates, B 2.7 mm reconstruction plate, C 2 large lag screws, or D 2.4 mm lag screw. Now, according to the Champy's lines of osteosynthesis, which I've mentioned in my class notes as well, in the symphysis region, we go for 2 plates. We go for 2 plates to counteract the torsional forces present at the symphysis. Alright, so 2.1 mini plates, 2.1 mm mini plates is correct. Alright, the second option says 2.7 mm reconstruction plate. Now 2.7 mm reconstruction plate is a thick, robust plate. Alright, its profile is much more bulkier than a 2.1 mm mini plate. Alright, in its all dimensions it is more bulkier. Alright, so it has greater height, length of recon plate. You can determine on your own. You can cut the plate wherever you require, and also thickness of the plate is more in comparison to a mini plate. Now, when you're using a single reconstruction plate at the mandibular symphysis, it is most of the times it is enough. It is enough, single-handedly enough to counteract the torsional forces. Because a reconstruction plate is thicker in profile, it is more robust, and we all know that it gives rigid fixation. It gives rigid fixation. So it is going to keep your fracture segments in place. Alright. So yes. And also, when you are using a single recon plate, the profile is such that you are not left with space to use another recon plate. Alright, because it is, the dimensions are such and it is so robust. Okay. And option C, yes, you use two large lag screws. So if it is a symphysis fracture, suppose this is the mandible, there is a symphysis fracture here, you will use two large lag screws. One you drill from this side and another from this side to keep the fracture fragments together. Alright. So yes, two lag screws are appropriate. What is not appropriate is one 2.4 mm lag screw. One lag screw will not be sufficient enough to counteract the torsional forces present at the mandibular symphysis. So this is incorrect and this is the answer. This is the incorrect treatment option. Okay. Now coming to question number 5. For an impacted third molar surgery, red line depicts which of the following? A, depth of impaction, B, angulation of tooth, C, direction of roots, and D, path of exit. So again, a very simple, straightforward, direct question. The answer here is depth of impaction. This is the correct answer. Before we move forward, we'll quickly just go through our war lines so that students who are new can quickly revise, although I have explained this in the class, but a quick revision. Alright. So your white line is at the level of the occlusal plane. It is traced from the occlusal plane of the first and the second molar backwards posteriorly over the third molar. So white line depicts the depth of impaction from the occlusal plane. Apart from that, amber line is traced from the interdental septum. Alright. So this is your amber line. Okay. This depicts the depth of impaction within the bone. Okay. And then we have the red line. So we drop a perpendicular from the amber line to the point of application of elevator. Alright. This is the red line. So it tells us about the depth of impaction in relation to the amber line. And what is the amber line? It is telling us the depth of impaction in relation to the bone. Hence, red line is depicting depth of impaction. Okay. Coming to the next question. In a patient with panfacial fractures with limited mouth opening, which method of intubation is most appropriate? So in our revision series also, I had taken up intubation. Alright, I had taken up intubation in my predictor series as well. So this was a simple question. The only thing that could cause confusion over here was limited mouth opening. Alright. Please pay attention to the word limited mouth opening. Limited means less. When it says restricted mouth opening, that means almost negligible or nil mouth opening. Okay. So now here the mouth opening is limited due to pain, due to edema, due to presence of fractures, and no other reason. Alright. And it says panfacial fractures. Panfacial fractures. The question says panfacial fractures. So orotracheal intubation is not the method of choice in maxillofacial trauma because we have to look for occlusion. Nasotracheal is also contraindicated since it's a panfacial fracture, so we may have fractures in the midfacial region around the nasal region, so that's why nasotracheal is not indicated. Cricothyrotomy is an emergency method of securing the airway till you get definitive airway, or it's a time buying procedure. And the last option is D, which is submental intubation is the foremost indication of a panfacial fracture. Alright, so this is your answer. Coming to the next question. This question is a clinical based question. Okay, so let's read it out. A patient underwent surgical extraction of mandibular third molar. Tablet augmentin and diclofenac plus paracetamol was prescribed twice daily. He saw smooth recovery for 3 days. However, on fourth day he presented with redness, pain, and foul smelling yellowish discharge from the socket. How will you proceed? Okay. Now, this type of a clinical scenario is pointing out towards 2-3 things. Foul smelling yellowish discharge from the socket is pointing towards pus. Alright. And since there is collection, this is progressing towards space infection. This is progressing towards space infection. And since 3 days have passed, this is the 4th day. Alright, this is the 4th day. So what has happened is, if we see the causative organisms of orofacial infections, alright, or any infection of the orofacial region, we always find mixed flora and fauna. Alright, when I say mixed species present, that means there is aerobic as well as anaerobic organisms which are present, and both these organisms are aerobic as well as anaerobic are responsible for causing infections. Okay, now the second thing you have to pay attention to is the patient has been given augmentin and diclofenac and paracetamol. So for antibiotics he was given just augmentin, and the rest were analgesics, anti-inflammatory, NSAIDs, whatever. Alright, now you have 4 options, and amongst this 4 you have to pick and choose the best that you will do for the patient to resolve the patient's infection which has started, and to prevent it from progressing further. You have to prevent it from progressing further, and you have to resolve it also. So the first option says increase the dose of augmentin to 1000 milligram TDS. Okay. B says add, second option says add metronidazole 400 milligram TDS. 3 says wait and watch. 4 says cut one suture and allow the collection to drain, irrigate the socket and place iodine dressing. Now wait and watch is definitely, there is collection, you are not going to wait and watch. Okay. Now what is missing in the medications that you have given is your anaerobic coverage. your anaerobic coverage is missing. So first of all, you will add augmentin. Metronidazole. You will add metronidazole. Alright. Now the second thing is there is collection that is happening. Alright. So you will have to drain. You have to do incision and drainage. But you already have access to the infection in the form of the extraction socket. So you do not need to place a separate incision. You do not need to place a separate incision because it says that there is already drainage present from the extraction socket. Alright, so that means there is a dependent pathway that the pus or the foul yellowish smelling discharge has established via the socket. That's why you do not need to give a separate incision. You will cut open one suture and allow the collection to drain. Your opening is only present. Now you will make the opening more patent. You will provide a pathway for the pus to flow out. So you'll cut one suture, allow the collection to drain, irrigate the socket. Alright, you will copiously irrigate the socket and place iodine dressing. Iodine dressing is to keep the area clean, keep it sterile, prevent food lodgement, and to basically it acts as a supportive measure. Cut one suture, allow the collection to drain, cover it with a protective iodine dressing, add metronidazole. Augmentin dose can continue the same. Maybe the patient has been given 625 TDS, 1000 milligram TDS. So since they have not mentioned anything regarding the augmentin dose, we can let the same dose continue. So the best options to pick and choose from these four statements are option 2 and 4. So D is your answer. Okay, D is your answer. So even for future, alright, I want to tell you all, whenever there is a clinical scenario, you have to think in a stepwise manner and then move forward. What the question has mentioned, what are the options being given to you? Do they justify what the history is stating in the question, and accordingly you have to answer. Okay. Now coming to question number 8, it says surgeon snort is described as single throw in one direction followed by one throw in single direction, I think in same direction. Double throw in one direction followed by two throws in opposite direction, and D is double throw in one direction followed by one throw in opposite direction. So here option D is the correct answer. Okay. So I'll just explain different types of knots. Okay. Now if you all have done suturing, I'm sure you all have done suturing of extraction sockets or of some lacerations during your undergraduate days. Even if you've not done on a patient, you might have been made to practice suturing on a cushion or on a small pillow or on a small piece of sponge. So whenever you are doing suturing, when you're tying the knot, or when someone is explaining you suturing, what do they tell us? If this is my artery forceps, alright, I will take the thread, throw it 2 times over my artery, alright, and then tighten it. The second time when I'm knotting it, I give one throw in the opposite direction and then tighten it. That is your surgeon's knot. So 2 throws in the same direction followed by one throw in the opposite direction. That is your surgeon's knot. That is what we all use when we are suturing. Okay, and that is the most safest, most secure knot because it prevents slippage. Alright, it prevents slippage. The knot is secured tightly and it prevents its opening up. Alright, so coming to the types of knots, the first one is reef knot, also known as square knot. Now what is a reef knot? Please understand, if you have two threads or two ropes together and you have to tie them together. Alright, so what you will do when you have two threads or two ropes and you have to tie their open ends together, you will make a cross and then tie it once and then again cross them over and tie it twice. So when you're tying two ends of two ropes, if you're tying ends of two ropes, that is when you use a reef knot. You will have to imagine these knots a little. Alright, so it is a secure knot used to join two pieces of ropes or cord. Alright, the second one is a surgeon's knot. This I explained you. It is a modification of the square knot. It is used in surgeries to provide safe and secure knot. Double throw in one direction followed by one throw in opposite direction. Alright, the third one is granny's knot. Alright, so if you have stitched a button or stitched a torn cloth, so you must have seen, once you are done securing the button or once you are done stitching the cloth, in the end when you have to secure the button or in the end when you have to tie the knot, you take the needle, alright, and you pass it between the last passed thread and take it out. Alright, so that is a granny's knot, the one which you use for securing buttons or clothes. Those are granny's knots. Alright, so they are kind of half knots. So to make them give them better strength or to make them more secure, what do? You keep on placing knots over knots over knots. You will understand if you have stitched a button or stitched a cloth. Alright, so once you are done securing the button, you will take the needle and the thread, pass it beneath from the previously passed thread and tie it, and again on top of this knot you will secure 2-3 knots. So that is your granny's knot. Alright, which is not used in surgeries. Granny's knot is not used in surgeries. So it is formed by tying two identical half knots on top of each other. Now, which of this is a non-resorbable suture? Option A is catgut, B polygalactin, C polypropylene, D polydioxanone. So the answer is polypropylene, or also known as proline. This is your answer. This is synthetic non-resorbable. So again, I had provided this table when we were studying suturing. Polypropylene is synthetic non-resorbable. Okay. Coming to the next question, that is question number 10. During genioplasty for correction of asymmetry, the critical point to adjust midline is. Alright. So this was a difficult question. This is again a postgraduate level question. I'll just explain you don't need to go into details. I'll just explain very briefly. So I'll read out the question again. It says, during genioplasty for correction of asymmetry, critical point to adjust midline is A. Menton, B. Gonion, C. Pogonion, D. Infradental. Alright. Now, infradental is not present on the chin. When we are talking about genioplasty, we are essentially talking about the correction of midline or asymmetry of the chin, right? Because genioplasty is a procedure done for chin. Alright, so infradental is not present on the chin and gonion is present at the angle. So this is also now there are two landmarks which correspond to the chin. One is pogonion, right, and one is menton. Okay. Now pogonion is the inferior most point on the bony symphysis. Right, inferior most point on the bony symphysis is pogonion. Right. And menton is the anterior point, right? Anterior point, and menton is a hard tissue as well as a soft tissue landmark. Okay. So the anterior most point present on the bony symphysis becomes your menton. Okay. And the corresponding point of it on the soft tissue becomes your soft tissue menton. Okay. Now when you are correcting the midline, when you are doing a straightening or a sliding genioplasty to correct the midline or correct the asymmetry, you are making sure that you match the menton, right? You match the menton, and also most importantly for aesthetics, we match the soft tissue menton. Bony, we will leave bony for now. All right, we will not speak of bony. Mostly when we are doing surgical planning, all right, we match the bony menton. But when we are assessing the patient on table, when we have done the genioplasty, when we have corrected the asymmetry before finally fixing it with plates and screws, we assess the midline on table via soft tissue menton, because that is what is going to be visible, that is what is going to be present aesthetically. Bony menton is something which will be covered under the soft tissues. Alright, so the soft tissue menton is one which is actually verified on table after correcting the midline, so that when the patient is looking at his or herself in the mirror, or when the patient is being looked at by other people, they will be able to make out that the midline has corrected. Alright, so menton is important for correction of symmetry. Just don't go into much details, just keep this in mind. Coming to question number 11, a 54-year-old male undergoing Lipot 1 osteotomy surgery under GA develops significant bradycardia of 33 beats per minute during mobilization of the maxilla. What is the most probable cause? A. Stimulation of the facial nerve. B. Stimulation of the trigeminal nerve. C. Deeper planes of anesthesia. And D. Due to opioids. So, let's see. Patient is undergoing Lipot 1 osteotomy. There is significant bradycardia of 33 beats per minute during mobilization of the maxilla. What is the most probable cause? So here they are speaking in terms of Trigemino-cardiac reflex or oculo-cardiac reflex. Okay. Now, this is a triad of decreased heart rate, that is bradycardia, decreased blood pressure, that is hypotension, and increased gastric mobility, that is nausea and vomiting. Okay. Why does this reflex develop? How does it develop? Again, let's not go into the details. What is required at your level, I'll just very briefly explain you why does this develop. It is due to crossover of trigeminal nerve and vagus nerve. They are closely crossing over. They are not contacting each other, but they're closely crossing over at the level of pons. So whenever there is a, let's say, a nasty or a stimulus to the trigeminal nerve, so there might be certain impulses that might get transmitted to the vagus nerve and lead to the stimulation of the vagus nerve. So whenever that happens, you will see these three clinical signs: bradycardia, hypotension, and nausea, vomiting. Fine. So the answer to this question is stimulation of trigeminal nerve, and whenever you are operating, say, on orbital floor fracture, on maxilla, on TMJ ankylosis or TMJ surgeries, this reflex can be elicited and you can see these clinical features in the patient. Okay. Now, another question related to the same concept, trigemino-cardiac reflex. It says, which of the following is not a component of trigemino-vagal reflex? Option A is bradycardia, B hypotension, C hypertension, increased gastric mobility, and B hypotension, C hypertension, and increased gastric mobility. So I just now told you that it is hypotension and there is no hypertension which is seen. So this is your answer. Okay. And I would like to tell you, we had discussed trigemino-cardiac reflex a couple of times, if I remember, on our WhatsApp group. So, and there also I told you regarding the triad. Okay. Now, coming to the next question, what does the term pitch refer to in relation to dentofacial arch? I'll read out the options. We'll come to the answer later. This is again a postgraduate level topic. I'll just give you a few visuals so that you can remember. The options say occlusal irregularity in frontal plane, occlusal irregularity in sagittal plane, midline discrepancy of the jaw, and the vertical defect of jaw. Okay. So I want all of you to imagine an aircraft, aeroplane. All right. So the anterior pointed portion of the airplane is known as the nose. All right. And the posterior most part of the airplane is known as the tail. All right. Just imagine you are standing in front of an aircraft. All right. The nose is pointing towards you. All right. And the posterior most end of the aircraft is the tail. All right. I'll just point it out over here. Okay. Fine. So let's first see what is yaw. Okay, so if you're standing in front of the airplane, all right, let us imagine this is the airplane, all right, and I'm standing in front of this. Okay, so if this, or let's imagine this is the airplane and you people are viewing it, all right, so this is the nose. If this airplane moves in, and this is moving in this direction. Okay, this is the yaw. All right, fine. Now the second concept is pitch. Second concept is pitch. So if this is the airplane, you people are viewing it from there. This is the airplane, this is the nose, this is the tail, and if the nose goes up and tail goes down, or if the nose goes down and tail goes up, so this is the pitch, movement in this direction. Okay, movement in this direction, this is the pitch. Okay, now let's come to roll. Okay. So if this is the airplane and if it is moving in clockwise or anti-clockwise direction. Alright, I'll just explain again. If this is moving in clockwise or anti-clockwise direction, if suppose if it is moving about its wings, alright, so if it is moving in clockwise direction, it is known as roll. Okay, so I'm going to explain again. First we will see yaw. Okay, this is, you have to imagine, yes, I'm explaining again, Samriddhi. You have to imagine that you are standing in front of the airplane. The pointed tip, anterior most part of the airplane is called the nose, and the posterior most part of the airplane is called as a tail. Okay, so if you are standing in front of the airplane and this is the nose, all right, so if this moves left or right, so if the nose moves left or right, all right, that is yaw. Movement in this direction is yaw. Fine. Now if this moves like this, if the nose goes up and down, so when the nose will go down, tail will go up, when the nose goes up, the tail will go down. If this moves in this direction, that is your pitch. Alright, so if you see, this becomes your movement in vertical plane. This becomes your movement in vertical plane. Alright, pitch. Okay, and if this moves like this in clockwise or counterclockwise direction, how the movement is being seen over here. So if one wing goes down, or if if another wing goes up and the other wing goes down, that is known as roll. So movement in this direction, like this, roll. Fine. Is it clear now? Please let me know if it is clear. This concept is a little difficult to understand, I know. Just remember the examples of airplanes. Please let me know if it is clear now. Is it clear? Okay. What about you, Samriddhi? Is it clear? So now you see, once you have done a Lefort 1 osteotomy, the image shows a Lefort 1 osteotomy. Okay. So if you consider this as the nose, alright, consider this as the nose and that as the tail. So once you have done a Lefort 1 osteotomy, you can move the mandible, alright, in according to the yaw, pitch and roll. Alright, you can take the anterior part of the maxilla up and tail down. Okay, you can take it in this direction, alright, left or right, and then you can do it counterclockwise or anti-clockwise. That is why there is relation of yaw, pitch and roll to Lefort 1 osteotomy, or two movements of the maxilla, alright, because a Lefort 1 osteotomy can correct the yaw, pitch and roll, alright. So for example, if a patient has a slanting maxilla, alright, so the left side occlusal plane is lower than the right side occlusal plane, so you can correct it, alright. That's why you can correct the maxilla, in terms of yaw, pitch and roll. That is why those terms are used. These yaw, pitch and roll are actually aviation terms, alright, but they can be correlated to the maxilla according to the movement that you are doing at the maxilla, alright. So to make it very simple, I have not gone into the technical definitions of these terms. Pitch is nose up or tail up, alright, so vertical direction. Yaw is nose moves from side to side, okay, and roll is a circular clockwise or anti-clockwise movement of the body as it moves forward. Okay, just remember a circular clockwise or anti-clockwise movement. Just this much would be sufficient. A circular clockwise or anti-clockwise movement, just this much for roll. Just remember these three lines. I'm not going into the technical definitions, okay, just remember these three things and remember these pictures, more than sufficient, alright. So this is actually, just a moment, so yeah, the answer here is vertical defect of the jaw. This is the pitch, okay, vertical defect of the jaw is the pitch. This is your roll, occlusal irregularity in frontal plane, alright, and midline discrepancy of the jaw is yaw. This is nothing. Occlusal irregularity in sagittal plane is nothing, okay. So just try to remember those one lines and the diagrams that I've told you. I hope it is clear. Just a moment. Okay. Coming to question number 14. Bony crepitus is observed in which of the following conditions? So the options are A. Rubbing of bone surface against each other in fracture. Anterior displacement causing audible sound in Wilkie's stage 2 TMD. Hollow sound heard when tapping the maxillary molars after Lefoot 1 fracture. And D is paper thin condylar cortex caused by expansile ameloblastoma of the mandible. Okay. So I would like to tell you, let's see one by one. We will leave option A side for a moment. Anterior disc displacement causing audible sound in Wilkie's stage 2 TMD is, these are grating, popping sounds. Alright, fine. Hollow sound heard when tapping maxillary molars after Lefoot 1 fracture. This is a cracked pot sound. Paper thin cortex caused by expansile ameloblastoma of the mandible is egg shell crackling. Okay. Now, rubbing of bone surface against each other in fracture. Alright, so if you remember, I had told you in the class that you have to do a mobility, bimanual mobility test when you're doing the palpation. Alright, so I had explained the action also in the class. You take your thumb and index finger, place your index finger on the tooth, one in front of the fracture where you're suspecting and one posterior, one anterior, and you place your thumb on the inferior border and move the mandible like this and in this direction. So when you're moving the mandible, the two bones, when they will rub against each other, they will give rise to grating sound. They will give rise to grating, sorry, not grating, they will give rise to, the bones will rub against each other, and also there will be air entrapment out there. There will be air entrapment out there. Fine. So that is known as bony crepitus. Alright, when there is a fracture, alright, and bones move against each other, alright, and the entrapped air which is present in between the fracture segments and the soft tissues, when they move in this environment, when they move against each other, and which also causes the movement of the air which is present in the surrounding tissues, that is known as bony crepitus. Bony crepitus. So option A refers to bony crepitus, and this is the answer. Okay. So coming to the last question, this was again a difficult question. Just a moment. Okay. Unilateral flattening of condyle with elongation of condylar neck is seen in asymptomatic female in her second decade, noted incidentally on an OPG. This most likely represents. Okay. So I'll tell you the answer first here. This is actually a difficult question. The answer is progressive condylar resorption. Okay. Now the first thing that we have is unilateral flattening of condyle with elongation of condylar neck, asymptomatic, female, second decade. That means 11 to 20 years of age. Noted incidentally on an OPG. Okay. Now if you ask me, only degenerative joint disease is something which is unilateral, rest all are bilateral. But unilateral flattening of condyle with elongation of condylar neck. Alright. So when the condyle flattens out, it gives a false appearance that the condylar neck has elongated. Okay. Asymptomatic means there is no pain swelling, no deranged occlusion, nothing. There are no symptoms. Female in the second decade. Alright, except for unilateral, all these features are consistent with progressive condylar resorption. Progressive condylar resorption is usually bilateral. But apart from this one clinical feature, rest all are clinical features of progressive condylar resorption. Okay. Now let me tell you why other three options are not correct. Ankylosing spondylitis is something that affects the spine. So that is why this is ruled out. Now, juvenile idiopathic arthritis. Wherever there is the word arthritis, there would be inflammation, there would be pain, there would be swelling. Right? This is also ruled out. Okay. Now, degenerative joint disease, option C. Now, degenerative joint disease can be again due to rheumatoid arthritis, it can be due to some infectious process, it can be due to maybe say tuberculosis. Alright, so and degenerative joint disease is also unilateral, but it will be associated with some symptoms. Degeneration, that means there would be, as the disease would progress, the patient will keep on developing certain symptoms like limited mouth opening, pain, alright, deviation. So this is also ruled out. Here the biggest catch is asymptomatic and female in the second decade. Classical presentations of progressive condylar resorption. Just 2-3 points out here, then we wind up the session. Progressive condylar resorption is also known as idiopathic condylar resorption or condylosis. Condition where the condyle, the bony knob at the end of the lower jaw, this actually means the condyle, alright, progressively resorbs. The condyle resorbs, alright, they have just tried to, the language is such that they mean that the condyle progressively resorbs, so that the round contour of the condyle is lost. You will just, it will give you a picture that just the neck is present. Okay. It is an uncommon aggressive degenerative disease of the temporomandible that mainly affects young women, and most importantly, this is asymptomatic. This is asymptomatic. It's not associated with any pain or any other clinical sign and symptom that would lead us to diagnosing this. Okay. So with that, we end this session. Alright. I wish you all the best for your INICET results. Thank you very much. If there are any doubts, you can ask me. Otherwise, we can wind up the session. You can ask me if there are any doubts. Otherwise, let's wind up the session. Okay. Thank you, students. Thank you so much.